Hello, listeners. Welcome back to Drug Diversion Insights. My guest today is Shealee Mitchell. Shealee is a diversion specialist with a background that gives her a unique perspective. She has been a pharmacy technician. She's a registered nurse. She holds a Master of Jurisprudence, and she served as a Chief Experience Officer. She's taking everything she learned about culture, relationships, patient experience, and applying it to one of healthcare's most sensitive challenges, drug diversion. Welcome, Shealee. It's great to have you on the podcast.
Thank you, Terry. I'm so excited to be here.
Start by giving us more of your background and how you got into your current role.
Well, I always like to tell people that if you feel any shame in your resume or have career ADHD, don't, because I have that for sure. And I think that every thing along the way that I participated in just prepared me for this role. I had so many jobs in the background just trying to figure out what I wanted to be when I grew up. And, everything that I worked at, from pharmacy tech to nurse, and all of the roles that I held as a nurse, from bedside and labor and delivery and PACU, OR, and then ultimately the emergency room and leadership, most definitely prepared me to work in drug diversion, where I feel like I finally found my spot. So I did not have that straight and narrow path where I, was the kid who said, this is what I want to be when I grow
Right.
up. And I think that's totally, fine. I think that all of those roles just made me ready for this one.
Yeah, no, I agree with you that diverse experiences, we certainly know what workflow looks like in every one of those areas, right? Or at least enough to know what questions to ask. And then your experience in pharmacy too gave you that insight. So I 100% agree with you, although it was probably frustrating along the way. Like, what? Where is my passion? So I'm glad that you found it. I'm glad you grew up and you're doing what you want to do.
Absolutely. Thank you.
Yeah.
Absolutely. Yes.
When we spoke previously, you told me that you told your leadership team you were going to spend, I believe it was your first 60 days, focused primarily on relationship building rather than jumping straight into investigations and monitoring, which may have been hard for you, may have been hard for them to hear, but I like that. I think that's extremely important, and it's a step that I think many people skip because they want to just jump right to it. So walk me through your decision. What made you prioritize culture first?
Well, having been a nurse at the bedside, I know that a lot of times we're just brought these policies, and we don't really understand the why behind them. Every once in a while they'll come from legislative changes or regulatory changes, and then we're just handed these things that make absolutely no sense to our workflow and often make our jobs harder. And I didn't want to be one of those things. I didn't want to be one of those policy changes that make a nurse's job harder. And if that happens, nurses are really good at either not participating or participating with pushback. And I felt like the rollout would be a lot easier if I had a relationship with all of the nursing staff as well as the CRNA staff, and they understood where I'm coming from, why I'm doing what I'm doing, and the foundations behind the policy changes. So that first 30 days I really lived in what was currently being done. I kind of did like a gap analysis and a review of what the hospital was doing, because they had a diversion program already in place. And I just wanted to see how it worked and where I could make improvements. And then that second 30 days, I started very slowly implementing those policy changes where I could, and just making some easy efficiency moves. But the rest of the time I went to staff meetings. I spent a lot of time on the floors. I worked side by side with nurses and leadership. I spent time in the OR with the CRNAs, watched a couple of cases to see how they pulled drugs and how they stored them, that sort of thing. So I could understand what their workflow looked like, so that the policy I implemented wasn't difficult for them and didn't make their work harder.
Yeah. Were you looking for anything in particular while you were doing these assessments and bringing culture into it? Or were you really just listening and giving them an opportunity to express themselves and to show you?
It actually was multifaceted. So number one, I wanted them to know who I was. I didn't want to be an invisible face behind an email. Those are often not followed up on or ignored when they don't know who you are. And it's difficult to get answers and follow through when that person is not humanized. So I wanted to, first break through that barrier. Secondly, I wanted to understand how things are done at our hospital in each one of those units so that my policies that I rolled out made sense. And because everything that I try to do, I try to base it on a common sense foundation. And so that way it doesn't, it flows into what we're currently doing and it's easy to implement. And so when I watch those workflows, I'm not necessarily looking for something they're doing wrong, or I'm not going to jump in there and say, hey, you're not supposed to do that. That wasn't my place during that 30-day period. It was what is traditionally done. This is the way we've always done it. I hate that sentence. But what could I, again, make more efficient and make my policy make sense to the way we did it at our hospital?
Right. Yeah. And I totally hear you. We have to stay within, there are certain things that we just have to get done and make sure they're done this way. I mean, there's a little bit of latitude, but you have to conform to the regulatory piece of it. But finding that balance of meeting the regulations, but also meeting everyday life. Right.
Right.
I told this story. I may have told it on a podcast, but for a while, one of my roles as medication safety officer at a hospital was to lead their medication safety committee. And this hospital did an excellent job of engaging frontline nurses in that. And so we had, I want to say like 25 people, maybe even a little bit more at these meetings, big, U-shaped table where we could all come together. Definitely pharmacy representation, but mostly it was frontline nurses. And, we talk about things, all medication safety related, not necessarily just controlled substances, but, when there was, we're seeing med errors or things that are not right and we have to change the workflow. So then as a pharmacist, right, I would like, okay, well, this is what we need to do. And then I get pushback and we had a relationship. So the pushback was, they were very honest. Sometimes I had to keep a very neutral face when they would tell me what they actually do in real life. But they would say, this isn't going to happen. I'm just telling you, we can't do this. And what was really important for me, though, not being a nurse, was I had someone in the room who was a nurse. And then she moved into quality and compliance. And so she knew, both sides. So I would always have a line of sight to her and she'd give me the signal, yeah, they're right. Versus don't listen to them. You can push through on this one,
Right.
because they're just making trouble. But it is important to work within what is realistic for them and to discern this is a workaround that is not necessary. It's just the way you've always done it, but we can do better.
Right. Absolutely.
Yeah.
100%. And we work very similarly to what you describe. We have basically 3 committees, so many more. I don't want to minimize it because there's so many moving parts when it comes to committees and decision making. But specifically for medication safety and drug diversion, we have 3 basic committees. We have the medication safety committee, where a lot of stuff flows through that. Our big drugs like insulin, heparin, those things that require a lot of oversight. Then we have our drug diversion response team, which are our frontline leaders from every department. We have nursing, we have HR, compliance, legal, pharmacy, any players that could potentially assist in making decisions meet monthly to discuss what I lovingly refer to as anything wonky, right? That we run through our diversion response team, and they help me make those immediate decisions. And then we also can, revise policy to fit those workflows. And like you said, if there's anything that shouldn't be receiving pushback, the diversion response team can help with that because one of our peer review leaders is on that team. And then also we have our MDT, which is our C-suite, our policy makers, our decision makers. And I meet with them quarterly to give them updates, data, things like that. And they're like the final say in what's going to happen as far as drug diversion and all decisions within the hospital, so that they stay consistently updated on what's happening with our drug diversion program.
That's great. Did you call them the MDT?
MDT, that's our multidisciplinary drug response team. Yeah.
Okay. All right. Okay, great. Yeah, so you've got some nice levels of committees and stuff that are there to assist you and then to help make those decisions. Your background as a chief experience officer, what did you do in that role, and has that shaped your approach? I mean, maybe that's why you came in approaching it differently with how you started out when you started in that role.
I definitely think that's true because culture is very close to my heart, very, very important to me. So I helped build a culture within a de novo startup company, built all of the HR and did like uh, gap analysis again of the workflow for the nurses we were bringing in, made sure that everything was laid out appropriately as far as their workspace and how the nurses were going to work together with the physicians, and made sure that we had a culture of education, of open communication, of transparency. All of those things are, I think, vital to the success of a company. And so I built on that and took those philosophies and kind of rolled it into our drug diversion response. I really want to make sure that the nurses feel safe when it comes to reporting. And so I'm someone they can come to and talk to, or even if they themselves are having an issue, I want them to feel like my office is an open door space where they could come and talk to me about that and not feel like I'm that big hammer that's going to come down and, make them feel like, they're going to be in trouble. I want them to feel like they could come and look for help.
Yeah, I think that's great. I love this message. It is so important. And I know from my past experience too, is, sometimes they get used to seeing you. And when they see you, it's like, oh no, what did I do? So you really have to be proactive in developing those relationships, which means taking time out of your day to maybe just go hang out and have a conversation. But we can't minimize the value of all of that because, yeah, it's what we do and identifying somebody and saving, hopefully making their life better ultimately, making patient safety better, saving the hospital, all of the legal issues, that's all gratifying. But I think that really for me, some of the most gratifying moments were when a staff member comes to you and says either, and in my med safety role, it's like, hey, these two drugs, they're like close together and I almost made a mistake. Or, you know what, can we switch this with this because, for this reason. So when they are starting to be proactive, then you know that my work here has been successful, right? Because they're engaged, they are communicating, they're not afraid, they know I'll listen instead of just, it's a black hole, nobody's going to do anything about it. So it's very gratifying.
It's literally like the most exciting part of the job.
Yeah.
When I open my email and a nurse has either reported on themselves, oh my gosh, accidentally held this drug too long, or, I forgot to waste something within a timely manner, whatever the email says. And they say, this is going to look weird. This is what happened. Here's my witness. And, they proactively report those things. It's very exciting for me that they felt safe enough to do that and they didn't try to hide or cover it up. Just like you said, it really is heartwarming that I'm making those connections. I really want to kind of brag a little on some of my nurses that have taken drug diversion and ran with it in a whole different direction. They own a piece of this drug diversion program for their entire unit. And I had nothing to do with that. Like they completely built something on their own. And that was like something that was so valuable to me because, they reach out to me and they ask for some data, they ask for some information, they ask for some reporting, but their internal drug diversion program is owned by the staff nurses and no leadership's even involved because they want to protect each other and protect their practice and protect their coworkers. And I think that's really one of our biggest wins.
That's great. Are you allowed to give us a specific example of how they've done that?
Absolutely.
Okay.
So they created what we refer to as a unit-based council. And it's made up of, like I said, it's made up of staff bedside nurses. And so they came together and said, like, how can we create our own drug diversion program within our unit and brainstorm together? And so some of the little rules that they created were an acronym. It's SADD. I remember it because we make a joke that you'll be sad if you forget to chart your drugs. And so this is charted. This is posted in the med room, in the bathroom, in the break room, everywhere for nurses to remember. If you pull a drug from the Pyxis, be sure that it makes it into the chart and that you're giving your controlled substances appropriately. Another thing that they implemented is every time they give shift report, one of the questions that they ask routinely is, are all of your controlled substances charted appropriately and did you waste appropriately? And that way they can check each other off and make sure that those things were all completed. And then they ask for just some data that I routinely collect so that they can post a report card and show how well they're doing. And this is all done in like a med surge piece of our hospital. And I have, since they have begun this program, I rarely have to do any investigations in that area for, basically practice mistakes.
Right.
And because they're all taking care of each other and double checking those charts. And it's really impressive how well it's working and how well they're taking care of each other. And I'm really proud of their success.
Very nice. And so you or whoever's monitoring your software that you have, spend less time looking at missing med alerts.
Exactly.
That's,
And
yeah,
even med errors. They're even protecting
yeah,
each other from med errors because they have such close eyes on their charting. So it's
yeah.
great.
And very important too. I mean, somebody could still be diverting on that unit, but everybody is very familiar with what diversion is and how to look and caring for each other. And so you would hope that if there is someone on that unit that is struggling, they either would maybe feel a little more comfortable getting help, or they would at least be noticed sooner.
Exactly.
Because yeah, they're peers. It's unfortunate when you encounter a facility where the staff, oh no, we don't have diversion. They're all confident and feeling good about their hospital, and it's like, okay, well, if that's what you think, then it's happening, and you're not gonna notice it because it's not on your radar.
One of our pieces of education, because we have a huge education program. It's part of our computer-based learning. It's part of our onboarding process, our new hire, everybody, and our residency program. They're educated on how our program works, what drug diversion is, and what the consequences are. But one of the things that I'm very careful to point out is that the opioid crisis is real everywhere in the United States. Diversion is a problem everywhere in the United States. And statistically, we lose one registered nurse every single day to overdose, according to national standards. And so, our goal here is not to get you in trouble or to get anyone in trouble or to investigate anyone. Our goal is to protect you as a nurse, as an employee, as a human, and also to make sure that everyone here is safe and making good decisions for our patients. So that is the primary focus of our drug diversion program. And hopefully that is now becoming the focus of every coworker and reminding them of their not only legal, but also ethical responsibility to report.
Okay. Yeah, good points. So let's talk about some of the barriers you have encountered. I know when we spoke before, you and I talked about that tension between pharmacy and nursing that is often there. We discussed that a little bit. So I'm guessing maybe there was a little bit of barriers there. What are the most common barriers you see between those two departments? What have you done? And have there been other barriers that you've encountered?
So I'm not sure where it comes from. But everywhere I've ever worked, there has just been this natural tension between pharmacy and nursing. And I think it's because our focuses are a little different and we are all advocating for patients in our own way. And so I think that's where that tension comes from. And everybody's in a hurry all the time. But pharmacists, I understand, having worked in the pharmacy, just why things maybe move a little bit slower because there's so many steps to getting a medication out. And when you're a nurse and you're understaffed and your things are crazy and you've got so many patients, you want it to be instant and sometimes it can't be. And I think that's really where that tension comes from. And so my goal is to really help both sides understand the perspective of the other. The nurse to understand how many steps the pharmacist has to go through. So sometimes I'll tell them, this is what the process looks like. And then the feedback I get is, I had no idea. I didn't know they had to go through all those things. I didn't know what was happening. I feel bad now that I got so mad. And that's typically what happens because they have no idea. They think I can just call the pharmacy and say, hey, I need this drug, and it should just come to me immediately. And they don't know all of the processes that has to go to get that drug to that nurse.
Mhm.
And then on the pharmacy side, again, I like to try to play that same card. You have to understand that that nurse is standing there and the patient's angry and frustrated and the doctor's angry and frustrated, and all of the anger and frustration is just being spilled back to you. So hopefully that we can overcome just that natural barrier. But like I said, it doesn't matter where I've worked, what pharmacy, what hospital, it's just naturally always there. But I will say that the team atmosphere and the partnership at JPS is wonderful. And we have a culture that says, don't be a jerk, which I love. It's one of our taglines. And people really live by that and they do take care of each other. And so I will say that it's probably less here than anywhere I've ever been.
Okay, very cool. So you didn't have to work too hard with getting those two departments to connect. Okay. What other barriers have you seen with your program? And how long have you been in your position?
I've been in my position since September of last year.
Okay, so just over a year. All right. I know there was a program in place.
Mhm.
So was it sort of on autopilot and you've just improved, or have you run into barriers?
I think the biggest barrier is just that it's a lot more structured. The previous program was there were just a lot of people involved, and whenever you have a lot of people involved in the program and you don't have one person that kind of streamlines it and takes it and does their thing, things are kind of ran how each individual person thinks it should be. And so, nurses can become, and I say nurses just because we deal with them the most. I don't want to pick on or target nurses, but that's definitely the department we deal with the most. They have the most touches of controlled substances. But whenever you have a lot of people that are dealing with a program, everyone has their own way of doing things. And so there can be some frustration when they deal with maybe one person and they say, how do I do this? And they guide them one direction, but then they deal with another and they're given a different direction. So there can be some frustration or confusion that just builds up because of that natural consequence. So one of my goals is to make it streamlined and consistent regardless of what role you're doing, where you're at, what drug it is, what's happening. No matter what, the process is implemented consistently across the board. And that really has decreased a lot of the frustration, anxiety, a lot of the irritation involved in it because they just know how to do it and they know what's going to happen. And so that's been very helpful.
Yeah. Do you have those same multiple people involved? You've just taken more ownership to kind of like the decision is this, and or do you not have that team with you?
It's kind of, I've got that team as kind of like backup, like if I'm on vacation or if I'm out of the office and that sort of thing. But now this piece has been really taken off their plate so they can focus
Gotcha.
on their primary job duties, which I think they're very grateful for. One of our my biggest partner is our medication safety officer, and she really was bombarded because drug diversion is a huge job. And I mean, it's my full-time job, and she was having to do both. And I know that it was a lot of work for her. So now we kind of partner on things, and I think it's a lot. I think it's a lot better for her because I have taken
Yeah.
those over.
Gotcha. So your position, it sounds like your position was new. Other before that, people were pitching in wherever they had to, and it fell to whoever, yeah, certain piece of it. Okay, now I get it.
Exactly. Yes.
All right. Yeah. Oh, so I'm sure it wasn't too hard to get them on board with
Oh,
working
no.
with you.
No, they were like,
Yeah.
here, let's do
Yeah.
this. Let's work together. Yeah, it was easy
Exactly.
partnership. Yes.
Yeah, exactly. You recently did a webinar, which I unfortunately did not have the opportunity to attend, but I've heard very good things about it. And I understand there were a ton of questions afterwards. So I want to pivot a little bit here and ask you, were there one or two themes with those questions that you noticed? And if so, I want to take a little bit of time to talk about that, because if people on the webinar had those questions, other listeners out there that didn't hear the webinar probably have some of the same questions.
So I think the questions that came in, there are two themes that really kind of stand out in my head. And the first was, how do you get feedback from people when you send out emails? As far as like nurse managers, staff nurses, investigation information, that sort of thing. How do you break through that barrier? And my number one piece of advice would be to humanize yourself and not just be a person behind the email. Go to the units, walk around and introduce yourself to people. At first, that's going to feel really awkward because they're going to think that you're there checking up on them. But you need to do this very often and just say hi. Don't give advice. Don't tell them they're doing anything wrong, nothing like that. Just say hello. Also, attend staff meetings, attend huddles, offer to be a piece of education whenever the nurse managers host any meetings for their staff. One of the coolest things I did was to go and do presentations for retreats for our leadership. That was really awesome. And so they could see like what my education looked like, what my goals were, what my focus was, and to learn that I really wanted to protect nursing and nurse practice and not, get everybody in trouble. The second piece of advice is to be sure that your goals and your program align with the vision of your executive team. Because if you don't make sure that you have leadership support and that you're doing what they have in mind, the chances of success with your program are lessened. If you're making sure that their vision is being implemented, you will have their complete backing, their complete support, and you'll have a place to go when you get pushback from those staff members or from those leaders. Then you can roll those issues up to your executive team, and they'll guide you and let you know what to do. But if you're not working with them and making sure that their vision is being put in place, then you lose that support as well.
What would you say to people that maybe don't have the support? Not that they're on, trying to do something that leadership doesn't approve of, but that leadership is either neutral or just they're not engaged. I mean, sometimes it's leadership that doesn't think you have a diversion problem, right? So they're kind of just going through the motions. Do you have any suggestions for people in those situations? Okay.
Absolutely, and I completely understand what you're saying. And sometimes it's just because they're so bombarded and they're so busy that they're just like, you're going to handle it. Good luck. I appreciate you, right? I meet with our executive team on a quarterly basis, and one of the things that I do is I present news articles from the DEA of things that are in like current in the news, fines to facilities when diversion occurs, something that may happen in a local area or, somewhere in the country that was a significant issue, especially if I can find something that may on the surface seem like not that big of a deal,
Mhm.
and then find that, how did it affect the facility, what the liability of the facility was, how to protect the facility from that sort of thing happening, and just making it real and bringing it home and keeping it at front of mind. I think those things are super valuable steps that you can take to help get that support when you run into those issues with your leadership team.
Right. Also doubles as job security too, right?
Oh, for sure. Yes, absolutely. That never hurts, right? Um,
Yeah.
the other biggest question that I had was how do you make your policy and procedure implementation more successful, and how do you get buy-in from staff? I think the number one thing you can do is education, because a lot of times nurses are so bombarded and so busy that they're not purposefully pushing back against you. They just don't know what to do, right? So if you have those computer-based learning, if you have lectures, if you have that presence at all of those staff meetings, even just handouts or posters you can put in the med room about what to do in weird circumstances, you're going to get more uh, buy-in to your procedures. So education is absolutely key, and having a place where they can pull those procedures and read them, even attaching them to the emails when something, you are in the process of doing an investigation, attach the process or procedure to that email so it's handy. That's another great way to get buy-in to your processes. But just make sure that it's available and you've done education on what to do if something does occur.
That's a great idea. Like with your nurse managers that may not get involved very often, but now there's a case and they know that there's a program, they know they're supposed to do something, but what is it? And so
Right.
attaching that, yeah, standard operating procedure workflow for them so they can see what's next steps. That's a great idea. Any other things or any particular advice? I mean, I think that really the crux of our conversation today is it comes down to communication and relationship building. And in that process, you can't help but naturally educate, right? It's kind of all bundled together. None of us, I mean, if you think about it, none of us want to be told what to do. And we certainly are not inclined, well, for those of us that have a little rebel in us, we're not inclined to do it if we don't think that there's a reason to do it. But if we can listen long enough to hear, a reason, we still might not necessarily agree, but at least we can see the logic and the reason and why it's important or important to you. And so, okay, I'll participate in this process.
Absolutely. And I think that's hits the nail on the head for sure. Um, and I think if I had one last piece of advice, it would be don't hesitate to involve human resources and nursing peer review. It is vital that the person involved in drug diversion understand what the nursing law in that state is. And they're huge. The Nurse Practice Act in Texas is like 129 pages or something crazy. So if you have somebody to support you that constantly deals in those legal aspects and knows exactly what nurse practice is supposed to look like, have them on your diversion response team. Have them as someone who you consistently meet with. I meet with our peer review leader weekly. And so if you have that person as somebody that you can brainstorm with, I think that also will make your investigations, your policies more powerful because they understand how it impacts nursing practice. And then on the flip side, in human resources, somebody a little bit up the ladder, like a director or manager in human resources that isn't going to be quick to maybe alert someone to the investigation or that sort of thing. Because I know that's a big fear for diversion officers and maybe why they are slow to include human resources. But somebody who you can brainstorm with about your company policy and human resource law, those things are really important. And I think that if you have someone that you can talk to again, that will make your policy and procedure a lot more powerful. And somebody that I work with on a daily basis and is actually a friend. So I highly recommend those two people being a part of your daily workflow.
Yeah, good point. Sometimes we don't know, well, we don't know it's not within our expertise, but it's important stuff and we kind of forget about those types of things. And I think also too, another piece of that is, and I always tell people, make sure your risk is very intimately involved, because they know things you don't know, right? HR
Absolutely.
can be hearing about something else that they haven't even thought could be related to diversion. But maybe it is related to working impaired and, things changing. And it's like, oh, this name is coming up for these complaints or what have you. And they haven't told you, but now you're saying something to them and they're going to connect the dots and like, oh, okay, maybe there's
Right.
more story.
Risk and compliance and legal are so intimately involved in this process. Like I forget to mention them because I run so many things through them. I call them so much and say, what do you think about this? Do you think this is a problem? Or we get a report and, how do you read this? This is what I read. And
Right.
so yeah, we work very closely together. I hate for us to have those pharmacy or nursing or CRNA blinders on, because it touches every single department in the hospital. And I think they should be included in those decision-making processes.
Absolutely, especially in the OR, because
Oh,
they
yeah.
they hold things to themselves, and so it's a very good chance that you will have no idea what is happening with a particular provider, but risk is going to know that something has happened in the OR, right?
Exactly. And they'll know about patterns we don't know about.
Yeah,
The same thing with peer review. They'll know
yeah,
about things with nursing that we don't know about, and we may just be adding to a checklist.
yeah,
So the more communication we have, the better.
yeah, 100%. All right. Well, thank you very much for your time, Shaylee. This was fun. I learned a lot from you, and I think the listeners will get a lot out of it as well.
Awesome. It's a pleasure, Terry. I really enjoyed this. Again, I learned a lot from you too. So thank you for having me.
Thank you.